MSC Nutrition is our Enteral specialty division of medical service company. In support of our healthcare partners, we have expanded our reach to offer our best-in-class service as a reliable and trusted enteral supplier throughout Ohio, Michigan, Indiana, and Wisconsin. MSC understands the role that nutrition plays in every facet of the healthcare continuum. With the goal of improving nutrition status and overall patient outcomes, we offer a wide range of home nutrition products, devices, and formulas to meet the specific enteral needs of our patients. By combining our rich history of caring with our dedicated team of experts, we assist our patients every step of the way. From our on-site liaison teams to our caring and knowledgeable support staff, we are here to navigate everything from insurance coverage to hands-on equipment training at delivery. MSC is committed to the success of our home enteral nutrition patients on their journey towards improved health. For more information about MSC Nutrition, please reach out to your local MSC territory manager or visit our website at www.medicalservicecode.com.
Medical Service Company would like to welcome Lisa Logan to this year's panel of speakers. Lisa Logan is an Enteral Clinical Program Manager for the McKesson Medical Surgical Extension Care Division. Lisa has been a registered dietitian and a certified nutrition support clinician for over 45 years. She is also a member of the ADA and ASPN. She has published nutrition articles and has held positions in multiple healthcare settings such as hospitals, rehabilitation centers, long-term care, and home care organizations. She has served as a guest speaker for various nationally known organizations and institutions, which include Cornell Medical Center, World Health Communications, Inc., Presbyterian St. Luke's Medical Center, Sandoz Pharmaceuticals, Inc., Abbey Medical, and McGaw, Inc. Today's lecture topic will discuss an evidence-based approach to selecting enteral formulas. Please submit any questions you have for Lisa by using the Engage tab. These questions will be reviewed during the live Q&A portion of the lecture. To receive credit for attending, please complete and submit the evaluation at the conclusion of this session. Enjoy the presentation.
Hello, everyone. It's a pleasure to be here on behalf of JSM. I'm going to be speaking about a really important topic, evidence-based approach to selecting enteral formulas. This is a topic that a lot of folks have been very interested in because really there are a vast number of enteral formulations on the market, and clinicians are oftentimes really overwhelmed to determine the appropriate formula for their patients, particularly in the home care setting. I wanted to make some disclosures prior to starting. Some of the information obtained in this presentation was obtained from the ASPN, American Society of Parenteral Enteral Nutrition clinical webinar series. My goals today and objectives really are intended to help explore the benefits and medical necessity criteria in selecting appropriate formulas, helping you really understand the various conditions that impact the selection of enteral products, particularly in the home care setting. And I really want to help folks become more aware of the various formulations out there, the different categories of formulas, and various considerations that are required to optimize patient care and outcomes. As all of you know, the history of enteral formulas has really evolved over the past 50 years. In the past, people would simply thinly blend food and infuse it through a feeding tube. And then what happened is hospitals obviously wanted to ease the administration of formulas, and they wanted to decrease the microbial contamination factor. So commercial foods were developed. And what followed is there was initially standard formulas, and then specialized formulas were developed for various disease states. And over the last 10 years, there really has been a shift of interest in blenderized natural whole foods or food-based formulas, with some being organic and non-GMO. So I'm really going to go through all the different categories and help you ascertain the best way to select enteral solutions. Let's talk about why enteral therapy really is the preferred method of feeding. First of all, feeding through the GI tract, enteral really means feeding through the GI tract. It's much more physiologic. Also, there's advantages to feeding through the GI tract versus parenteral feeding, which is IV feeding. You preserve gut function and integrity. There have been studies that have repeatedly shown that you decrease the likelihood of bacterial translocation when you feed through the GI tract. Also, you preserve immunologic status. How? Well, you help maintain GALT, which is the gut-associated lymphoid tissue, and that helps improve immune status. Enteral therapy is much less costly than parenteral nutrition, and it's very easily accessible now. There's different routes that you can place tubes in, nasogastric, nasojejunal, and now you can even place tubes through the GI tract endoscopically and radiographically. So feeding through the GI tract has really become a pretty standard way of a modality to help patients get adequate nutrition. There are different types of enteral nutrition, as you know. There's oral supplements and there's tube feeding formulas. Now, oral supplements are often given for patients who just are not able to consume enough nutrition orally. So you sometimes give them a supplement 1 to 3 times a day to kind of close the nutritional gap. But then there's the other subset of patients, especially in the home care space, that need a full tube feeding because that's where the majority of nutrition support is provided through the tube, and they're unable sometimes to eat, and they need a tube feeding. So there's many patients where tube feeding is the main route of feeding. I want to talk about now how we as clinicians determine the best formula for our patients. And this is somewhat confusing because, disease-specific formulas and specialty formulas are classified by the FDA as medical foods. And therefore, there is a lot of lack of evidence from high-quality clinical trials to validate these formula claims. So fortunately, there are professional organizations out there that you see listed on this slide that provide clinician guidelines going forward on how to select the appropriate formula for our patients. And these, I'm going to kind of just quickly review these organizations. ASPEN, again, is the American Society of Parenteral Nutrition. SCCM is the Society of Critical Care Medicine. EAL is the Evidence Analysis Library. That's from ADA, the American Dietetic Association. CCPG is the Canadian Critical Care Nutrition Guidelines. ASPEN is the European side of ASPEN. It's the European Society of Parenteral Nutrition. Then there's UK guidelines, and there's also an excellent program by ASPEN. There's a core curriculum that also summarizes many of these guidelines. So this is really what we have as clinicians to utilize to be selecting enteral solutions. And 2009 was the first time they came up with some of these guidelines. I'm going to be reviewing the most recent recommendations by these professional organizations. Let's talk about formula selection. There's criteria that you need to think about before you select a formula. The obvious one would be the nutritional status of the patient. Are they malnourished? Are they hypermetabolic? What's going on clinically? That's the first thing you have to look at. So utilizing a dietitian to help assess the patient's caloric needs and all their other nutrition needs is key. But you also need to look at other things like the functional status of the GI tract, the digestive and absorptive capacity of the resident. So I just wanted to review this slide briefly. When the GI tract is impaired by illness, what happens? Disease or surgery issues can complicate the process of digestion and absorption. And this slide just illustrates how if there's maldigestion, there's an inability to break down food into its simple nutrients, or if there's malabsorption, there's an inability or problem absorbing nutrients. Most of the absorptive capacity is in the small intestine, which is about 20 feet long, and it's the upper 2/3 that are responsible for absorption. So if patients, for example, have issues like, bowel motility problems, inflammatory bowel disease issues like Crohn's disease or short bowel syndrome, it's going to impact their ability to absorb and digest nutrients. So therefore, the formula that you select will have to be modified. What other things do we think about? We think about macro and micronutrient content of the formula. What is that? Well, macronutrients are primarily carbohydrate, protein, and fat. And micronutrients are really the vitamins, the minerals, electrolytes, and things like that in the formula. So let's go through the key macronutrients that we have to think about. First of all, you think about carbohydrate. Carbohydrate is a very preferred fuel source. The white cells and the glucose-dependent tissues rely on carbohydrates. That usually contributes to at least 40 to 90% of the total calories in most enteral formulas. And it can be in the form of corn syrup solids, hydrolyzed corn starch, maltodextrin, sucrose, and fructose. The next thing we need to think about is protein. Protein is essential, and it comes in different forms. There's intact or polymeric type of protein, and that's typically like whole protein or protein isolates like casein, soy, whey, egg albumin, things like that. Or there's elemental or pre-digested protein, or hydrolyzed it's called. That's protein in the form of di and tripeptides, amino acids. That's typically used for people who have malabsorption issues and maldigestion issues. And then lastly, fat. Fat is key. It's a concentrated source of energy, and fat is, really important to be included in a formula. There's different types of fats. There are fats like for essential fatty acids, linoleic and linolenic acid, to provide the essential fatty acids patients need. There's also different other types of fats, whether you choose a formula that has omega-3 fatty acids. Those are anti-inflammatory fats like ALA, DHA, and EPA, you've heard of those, or the long-chain fats, again, where you get the linoleic and linolenic acid. The components in that are typically safflower, canola, corn oil, things like that. And then sometimes products have a different kind of fat called MCT oil. MCT is medium-chain triglycerides. They're rapidly absorbed as free fatty acids through the portal system. They do not require chylomicron formation or bile salts for digestion and absorption. So people like, for example, that have steatorrhea, fat malabsorption, that could be a choice for them. So it's really, you really have to look at the whole picture with regard to macronutrients. The other thing you got to consider is fiber. There's different types of fiber, but you all know that really fiber is needed to help maintain bowel regularity, prevent constipation, and help decrease the incidence of diarrhea. And there's different types of fiber. There's soluble fiber, which is fermentable fiber. And what happens is the bacteria ferment the soluble fiber so that it produces something called short chains, SCFA, short chain fatty acids in the colon. And these short chain fatty acids are very beneficial for the colonocytes. So soluble fiber, by producing these short chain fatty acids, is a very beneficial thing for patients. Then there's insoluble fiber, which is non-fermentable, and that decreases transit time by increasing fecal weight. Sources of that would be like soy, guar gum, and pectin, for example. So I did want to mention that. Now, the benefit of fiber really is that including these prebiotic fibers help the benefit the host by stimulating growth and also helping with providing good bacteria for the gut wall. And prebiotic fibers you're oftentimes going to see in these formulas are fructooligosaccharides called FOS and inulin. So I wanted to mention those. And this slide just illustrates there was a lot of hepatology magazines that support the use of prebiotics and sometimes probiotics because these prebiotic fibers really increase the number of beneficial anaerobic bacteria, and they help decrease pathogenic microorganisms. So it's, and probiotics that you've heard about really became observed in the 1900s, and that has been shown to increase intestinal balance as well. So fiber is an essential component to look at when you're selecting products. Let's talk about, the efficaciousness of using fiber. This slide by Aspen summarizes their thoughts on it, as well as the CCPG and evidence-based library. What they suggest is that soluble fiber may benefit hemodynamically stable patients with diarrhea, but they recommend avoiding insoluble fiber or any fiber you should avoid for sure if a patient has bowel ischemia or severe dysmotility. So Aspen and Society of Critical Care Medicine recommend that. Now, there's insufficient evidence, according to CCPG, that fiber is helpful in critical illness. It's not contraindicated, but they say the evidence-based library, you should consider soluble fiber. So you can see there is a difference in opinion on when fiber should necessarily be used, but you certainly don't want to use it for bowel ischemia or severe dysmotility. The other thing that you have to think about when you're selecting an enteral solution is the water and electrolytes, fluid requirements, because really it's important to think about that because fluid is an essential nutrient, really. And the standard formulas, which are the 1 cal per cc formula, the standard formulas typically are about 85% free water. The more calorically dense formulas like the 2 cal formulas have less free water, 70%. So keep in mind that water is something we think about when we select formulas for our patients. Electrolytes are also key because if a patient has organ dysfunction, hepatic, renal issues, you have to modify the amount of electrolytes, particularly potassium, sodium, phosphate, and especially like with CHF, sodium. So looking at electrolytes in your solutions as well as the water needs of the patient are key. And patients oftentimes do need water flushes. Tap water is safe for most healthy individuals, but you got to make sure the water supply is safely tested because some patients can get nosocomial infections if the tap water is not, safe, and other issues can happen. Immunocompromised patients are critically ill. Oftentimes, Aspen does recommend sterile water for those patients. So those are the things we need to think about. I did want to quickly mention here that cost and packaging come into play. Formulas can come in either, cartons or cans or ready-to-hang solutions, so that is also a factor you think about if someone's on a pump and you want to feed them with a ready-to-hang system versus putting, solutions, putting cartons in every 4 hours in the bag. That's something that impacts what folks choose as well. Let's talk now about the enteral formula categories. There are 6 major categories: polymeric, which is intact or standard formulas; nutrient dense; elemental or hydrolyzed; condition-specific or disease-specific formulas; modular formula additives; and the last category category I'm going to talk about is blenderized or organic formulas. Okay, so let's go through each of these separately. When you talk about intact or standard formulas, what really are they? They go through the normal digestion and absorption process. They mimic what you would get in food. They're very complete formulas in terms of micronutrients and macronutrients, and usually in a liter to 1,500, you get the RDA for the vitamins and minerals you need. And that's commonly what most people are on, are the standard formulas. The next category is nutrient dense. Nutrient dense means that it's more calorically concentrated. It's 1.5 to 2 calories per cc. Some contain fiber, some don't. Again, most of all these products are lactose-free, the same with the standard products, and they are formulated for adult and pediatric populations. The next category is elemental. Again, we discussed this for malabsorption and maldigestion. They're more the amino acids, mono and disaccharides. They're oftentimes called peptide formulations. And again, they're beneficial for patients with persistent diarrhea or pancreatic disorders or other malabsorptive conditions. And with these elemental diets, a lot of the fat, as I mentioned earlier, is probably in the form of medium chain triglycerides because, again, they're helpful for patients with steatorrhea and lymphatic drainage issues, and they don't require, bowel salts or chylomicron activity. So, and these elemental formulas vary in the calories per cc. They can be 1 to 1.5 calories per cc. Since they're mostly the elemental or pre-digested, they tend to be more hypertonic or hyperosmolar because the particles are very small, so it makes them more hypertonic. And then there's obviously the condition-specific or the disease-specific category for patients. There's pediatric formulas, of course, but there's diabetic, pulmonary, renal, and immune-enhancing formulas. And I'm going to go through the evidence-based guidelines that I have on those formulations. But in general, I think all of us as clinicians should ask these questions prior to going on a specialty formula. Do you have a patient that does not tolerate a standard formula? That's the first question. If they tolerate it, they probably obviously don't need a specialized formula. Do you have a patient that has impaired GI function, short bowel syndrome, chronic diarrhea or absorption issues, malabsorption issues? Do you have a patient with non-healing wounds that maybe needs a specialized immune modulating formula or one with higher protein? Does a patient have severe food allergies or needs a specific metabolic formula? For example, patients with PKU, those inborn error of metabolism patients who need specific formulas. So all these questions really should be asked prior to using a specialty formula. I did want to mention that there's another category of formulas called modular additives. And modular formulas really are typically single additives that are added to either an oral diet or a tube feeding to enhance a nutrient, whether it be adding carbohydrate powders, protein, fat additives, fiber, whatever. Mostly what's used are protein additives that you add to formulas to give patients who have higher protein needs. This is something that you should consider. It's an extra step for nursing to use modular additives. So it's preferential to try to select formulas that already have extra protein in it. There's a lot of high protein formulas out there, and ones with extra fiber so that you don't need to use these that frequently. So I did want to mention that. So what are the guidelines by Aspen and ESPN? Well, the European Society of Parenteral Nutrition guideline really said the first line of selection in home enteral nutrition and acute and critical care should be standard polymeric formulas, unless there's a justification for a blended tube feeding. They also stated in 2022 that standard commercial formulas for patients receiving home enteral nutrition without diarrhea, constipation, or diabetes. Now, if they have those issues, then you have to consider a specialty formula. And they also recommend using fiber-containing formulas for patients with diarrhea and constipation. Aspen and Society of Critical Care Medicine in 2016 basically said critically ill patients should use standard polymeric formulas. So the thing that I wanted to mention here is there really is a lack of clinical evidence showing benefit for the use of disease-specific formulas or specialty formulas over standard formulas in general. But there's obviously situations where it is warranted. I want to talk about the nutrient-dense formulas. Those are the formulas that are more concentrated. They're typically 1.5 to 2 to 2.25 calories per cc. And they're really preferential oftentimes in home enteral nutrition patients where you're trying to liberalize the time that they're off, say, the pump. If you give a more concentrated feeding, they can be off during the day, but you oftentimes have to remember to give them free water during the day, of course. But nutrient-dense formulas can be used in those situations. But Aspen and Espen recommend definitely using concentrated nutrient-dense formulas for patients with respiratory distress requiring volume restriction, or patients like cirrhotic patients with ascites, CHF patients, things like that. So nutrient-dense formulas really are useful in patients with these kind of conditions or acute respiratory failure patients that have volume overload. High protein, this comes up a lot. When should we give high protein? Well, this slide this is way back in 2009, but Aspen and a lot of the organizations said for sure give high protein for trauma, septic burn, surgical, medical ICU patients, but then CCPG didn't find enough evidence for head injury or critical illness. Other people have. There's a debate going on about that, but oftentimes the critically ill, of course, they're hypermetabolic. They do need more protein. Espen recommends for sure pancreatitis patients need high protein. They're very hypermetabolic, as well as wound healing. High proteins needed. The revised National Pressure Injury Advisory Panel recommends for stage 2 or greater pressure injuries, you definitely need to give high calorie, high protein, oftentimes extra arginine, zinc, and antioxidants for patients with wounds. So that's something really to keep in mind. The other thing I wanted to mention is the type of protein. There's been a lot of debate about, what type of protein should you use? Soy, casein, whey. There's been studies that have shown that maybe whey can be beneficial for people with gastric emptying issues because whey, for whatever reason, remains liquid in the stomach longer, so it may empty more quicker. So with motility disorders, some people use whey, but others say, casein and soy is good. So there really isn't, the verdict is not out yet on, what exact type of protein. However, you just got to make sure they get enough protein so they don't catabolize their own, protein stores. And also, you don't want to put a patient into gluconeogenesis. You want to make sure they get enough overall calories and carbohydrates so they don't use the protein you give them for energy. Let's talk about elemental. What are the guidelines? Well, this is a great summary on that. Aspen and SCCM recommend to start with a standard formula. And like, for example, in acute pancreatitis. But if there is enteral nutrition intolerance, they recommend transitioning to a small peptide formulation with MCT or fat-free formula in moderate to severe pancreatitis. In 2020, ESPEN, the European Society, felt that you should use standard formulas in acute pancreatitis, but some semi-elemental formulas may be beneficial in severe acute pancreatitis with malabsorption. And for patients with chronic pancreatitis who are intolerant to standard formulas, they definitely recommend using semi-elemental formulas with MCT. there have been a lot of limited research to analyze the efficacy of semi-elemental formulas in terms of cost versus benefit outcomes when compared with standard formulas. So more research has to be done on this. But ESPEN does recommend also that patients with cerebral palsy experiencing like pancreatic exocrine insufficiency would benefit from elemental hydrolyzed formulas. So you really got to evaluate case by case your patient, see how they're tolerating the standard formula. Are they having diarrhea, and do they need these pre-digested nutrients to have less side effects with your GI tract? Diabetes. Let's talk about this. Diabetes is there's a lot of diabetic formulas out there, and really they're intended for individuals with glucose intolerance to reduce the incidence of hypoglycemia. These diabetic formulas are higher in fat, 40% fat, typically 40% carb, and 20% protein. And this fiber and fat content may slow gastric emptying and prevent elevated blood sugars. So what do you think about? Well, one thing I immediately think about is if it's a non-insulin dependent diabetic and you use fiber, fiber itself may help prevent elevated blood sugars. So you may want to consider that before you go right to a diabetic formula. These are some of the guidelines that ESPEN and CCPG came out with, but they recommend like a low sugar enteral formula with slow digestible carbohydrates enriched in unsaturated fatty acids, especially the mono, may be used in patients who have diabetes and are receiving home enteral nutrition. So again, if you feel that patients' blood sugars are not being stabilized with insulin and these type of diabetic formulas are helpful, you should use them. 2015, Canadian Critical Care Nutrition Guidelines stated no recommendation for patients who were critically ill due to insufficient data to recommend low carbohydrate diets in conjunction with insulin. So there's, back and forth on this, but I think that's where the dietitian really needs to assess, the stability of the diabetic patient to see if these diabetic formulas are going to be helpful. And keep in mind, since these diabetic formulas are higher in fat, fat does slow gastric emptying. If some diabetic has bad gastroparesis, they may have issues unless the type of fat is more, medium chain triglyceride type of solution. Aspen came out with this a while back, and this was, I thought, quite interesting. They said there was insufficient evidence regarding cost of medical care, length of stay, infectious complication, or days of mechanical ventilation in critically ill patients with diabetes. There was just not enough to support diabetic formulas. And they thought, and then Aspen basically stated here that it's really important not to overfeed in diabetes and really only to consider diabetic specific products if patients have problem with glycemic control despite insulin. So I thought this was a good summary. Pulmonary formulas, they came about to decrease CO2 production. What happened? They said patients that were having difficulty being weaned from ventilators, they thought, okay, we'll lower the carbohydrate, increase the fat, they'll have less CO2 production, and we can wean them quicker. That's why those products came out initially. And some of these pulmonary formulas also may contain omega-3 fatty acids because they're anti-inflammatory, a lot of calorically dense. What have folks said about this? Well, Aspen and Society of Critical Care Medicine in 2016, these said basically to consider fluid-restricted, energy-dense formulas, the nutrient-dense formulas in acute respiratory failure with volume overload. They didn't think the pulmonary formulas were really necessary. No recommendation for specialty formulas, anti-inflammatory fats, and antioxidants. That's what they said. They also did not recommend the use of pulmonary formulas in acute respiratory failure. They just didn't find outcome data to support these specialized pulmonary formulas. In 2015, Canadian Critical Care Guidelines said maybe we should recommend fish oils, borage oils, plus antioxidants in acute lung injury and ARDS, acute respiratory distress syndrome. But there was insufficient data to make a recommendation on fish oil supplementation alone. So you can see that in general, you try a nutrient-dense formula, and if, there's issues, maybe you go to a more advanced formula, but typically those usually are what is being recommended. And this came out from Aspen too in ICU. They didn't recommend, these low carbohydrate, high fat pulmonary formulas for patients. And there was just insufficient data to support the cost of these. So that's why I think a lot of the pulmonary formulas aren't being used as often as they were in the past when this first came out, because people were thinking, if we use a pulmonary formula, we're going to lower the respiratory quotient, we can wean them off the vent. These studies don't substantiate doing that at this time. Let's talk about renal formulas, kidney failure formulas. What do they have? They have lower amount of electrolytes, primarily potassium, sodium, and phosphate. The protein content varies with regard to the amount of essential and non-essential amino acids, and they're mostly calorically dense. The guidelines on this basically state, by Aspen and SCCM in 2016, they recommend using a standard formula in acute kidney injury, acute renal failure. They only recommend really using a renal formula with the appropriate electrolyte profile, which is going to be less usually potassium and phosphate, in patients who have abnormalities in electrolytes that are out of whack. So if you have a patient that's pretty stable, they don't recommend using these renal failure formulas. However, patients who are getting continuous renal replacement therapy, CRRT, you really do have to provide enough protein, 2.5 grams per kilogram per day in patients undergoing this type of therapy. So that is what's recommended by this group. 2021, Aspen talked about acute and chronic kidney disease patients, and they again recommended standard formulas to meet the protein goals based on the disease state, and only to use renal failure formulas if there are electrolyte and fluid disturbances. They didn't think that you should rush to a renal failure formula. Now, if they're being dialyzed, typically they won't need a renal failure formula. If they're not being dialyzed, I know there's been some debate, patients with high blood urea nitrogens, if you should use just the essential amino acids. But again, it's on an individual basis for that. Let's talk about hepatic formulas. This was a big topic way back 25 years ago. They came out with products that were high in branched chain amino acids, low in aromatic amino acids. They thought it could prevent hepatic encephalopathy, along with the lactulose and things like that. What they found when they did research, 2016, Aspen and SCCM came up with just use a standard formula in ICU patients with acute and chronic liver disease. Really, in 2020, they stated there's no evidence to support enriched branched chain amino acid formulas. They do not really improve outcome from what they saw. However, branched chain amino acids can be beneficial in hepatic encephalopathy. That was stated. Immune enhancing. What are immune enhancing constituents? Arginine, glutamine, fish oils, nucleotides. These are pharmacologic active substances that really are supposed to help modulate immune function. This is a hot topic in this day and age, and I wanted to talk about these products are very expensive, sometimes needed, but I wanted to talk about the data on that. First, I want to go through each of them individually. Arginine, which is a conditional essential amino acid, it's metabolized by the liver. Arginine is a big topic because I know in wound healing, it's an integral part of the inflammatory process that helps with tissue repair and vascular permeability. Be aware, arginine in excess increases nitric oxide production. What is nitric oxide? It's a vasodilator. So you got to really be careful in septic patients who are hypertensive to give too much arginine to. So unless the patient's hemodynamically stable, you don't want to give arginine. Glutamine, the most abundant free amino acid in circulation. It's really important for gout. It's the preferred fuse site for enterocytes. And research has shown that giving glutamine can help possibly reduce rates of infection and help with burn and trauma patients. So what does the literature say? The literature says that in stress and hypermetabolic states, glutamine concentrations do drop. It is contraindicated in liver disease with elevated pneumonia. So I wanted to mention that. And it does transport nitrogen in the body. Omega-3 fatty acids. Omega-3 fatty acids metabolize to prostaglandins 3 and the 5 series. They're anti-inflammatory. You've heard of those. There's a lot of over-the-counter supplements that have alpha-linolenic acid, EPA, DHA, and they're really the anti-inflammatory components because omega-6 are inflammatory. Nucleotides, they're needed for cellular proliferation and they help with immunity and the clearance of pathogens. They're small compounds found in all cells to synthesize RNA and DNA, and it has been shown that when there's a low level of nucleotides, there's a reduced adaptive mediated immune response. Oftentimes, nucleotides are used in combination with glutamine, arginine, and omega-3 fatty acids. So what does this all mean? It means that there's a limited number of studies with nucleic acids and antioxidants. They can't really differentiate what is making the difference. Is it the glutamine, arginine? Because they're really all compiled typically in the same formulas. So really, more highly randomized controlled trials are needed to come out with, which component is making the difference. So these are the guidelines that I wanted to go through with you that, Aspen had come out with. They recommend arginine, glutamine, nucleic acids, omega-3 fatty acids, and antioxidants for surgical ICU, trauma, burn, head and neck cancer patients, mechanical ventilation patients. You don't want to give, again, these immune-enhancing patients, you don't want to give them these products if they're severely septic. And as far as reducing infection complications in some critically ill patients, the studies by EAL are pretty limited on that. Arginine, again, really be careful with severe sepsis, and the mortality in some of the studies with critically ill showed that some patients actually did worse. So it's on and off with this arginine in terms of whether to give it, but there are some studies obviously to support it, certainly for wound healing and that kind of thing. Glutamine really showed benefit in burn and trauma patients. Supplemental glutamine, they definitely recommend if a patient has, is a mixed ICU patient with burn and trauma, but routine supplementation is not recommended. So there's got to be more studies on some of these immune modulating formulas to know when exactly to give it, and also the quantities to give. I don't think that's been totally outlined clearly. As far as fish oils, borage oils, and antioxidants, Aspen and SCCM recommended for ARDS and acute lung injury because they are anti-inflammatory, and CCPG said it may be considered, but they didn't take a real stand on that one. So in general, what should we do? These guidelines from 2016 says with severe trauma, definitely consider immune-enhancing formulas with arginine and fish oils and the other nutrients mentioned. Recommend immune-enhancing formulas with arginine and the omega-3 supplement in patients who are being treated with brain injury. Also, recommend use against the use of immune or metabolic modulating formulas if someone's sepsis. So these are pretty good general guidelines you can follow. 2021 Aspen practice guidelines said really for post-op patients, they recommend standard whole protein formulas. However, patients who are malnourished and have major surgical cancer, they do recommend enriched enteral nutrition with arginine, omega-3 fatty acids, and ribonucleotides, giving perioperatively and postoperatively. They have been shown to help surgical outcomes. So that was a positive thing. I wanted to switch gears here and just end it with the last category, blenderized tube feedings. Why has this become so paramount these days? It's because dietary guidelines for Americans now emphasize a diet that's rich in whole foods. And conventional formulas have a lot of refined nutrients, sugars, processed corn and soy ingredients, emulsifiers, which aren't good. And research has shown that these refined nutrients drive inflammation. Inflammation drives a lot of autoimmune issues, a lot of dysbiosis, so gut permeability issues that can lead to leaky gut, that contribute to GI distress. So functional medicine has really become an important concept now and how we deal with nutrition. So whole food formulas, this blenderized, is really gained a lot of traction. There's fermentable fibers, there's phytonutrients in these formulas. And a lot of patients at home are like, I want real food-based formulas. I want a healthy microbiome. I want a better glycemic control and less inflammation, and it may help the immune system. So that's where all this came from. So there's formulas out there now that are organic, non-GMO, because, having more organic nutrients in formulas is less toxic. That's been proven. There's less pesticides that can harm the body. Organic foods, again, have been shown to help immunity and to decrease the risk of potentially, autoimmune type of stuff. So a lot of the products have USDA organic on them or certified organic, and a lot of your patients are going to want these kind of products. There are HCPCS codes now that manufacturers get for these products so that they are billable. Again, the cost of these sometimes exceeds reimbursement. So suppliers or DMEs sometimes, have trouble getting the proper reimbursement to provide these products, but it is something, so some patients pay out of pocket. There has been research on blenderized tube feedings by patients themselves. There was a survey done in 2018, and it showed that these are some of the reasons they wanted to use whole foods. They wanted to for health reasons, tube feeding tolerance reasons, and they had less side effects from other formulas. So it really is gaining a lot of traction. It's something you need to be aware of. General guidelines that you should be aware of before considering blenderized tube feeding is ensure the adequacy of delivery in the home environment. That's key. May not be appropriate for medically unstable patients or patients with immature stomacytes because there may be a higher risk for infection and tube occlusion. Patients need a tube that's at least 14 French or greater to prevent tube occlusion. And some of the products are only made for bolus feeding because there's less chance of clogging, although there is a pump that's coming out now that is being touted for blenderized tube feedings because it does not clog like some other pumps clog. So, the technologically, manufacturers are now really tailor-making their advances to being able to provide blenderized tube feeding for the home care patient who really wants more health conscious and wants to be more healthy. I did want to just quickly summarize that there are HCPCS codes for many of these commercially available products. The retail products don't always have a HCPCS code. The institutional products do, but the specialty nutrients, which are the, B4153, B4154, B4155, B4149, are much more expensive. There's got to be medical justification for the use of these by, I know, Medicare Part B and some insurers. So you just can't willy-nilly use a specialized formula. You really have to have medical necessity criteria for the use of that. I wanted to summarize by just saying, you can see there's a wide variety of enteral formulas that exist. And enteral nutrition selection is challenging in today's market with the limited evidence-based research out there. And you have to be aware that there's a lot of formula shortages that make it more challenging. There's a lot of discontinuation of products due to these shortages. And despite the expansive, diversity of formula options, standard formulas really are the mainstream choice of what you should choose for most patients for standard care in the home enteral nutrition setting. Clinicians really should, as this slide summarizes, Select according to a patient's nutrition requirements and their organ function. Look at their clinical state. GI and organ function are key factors to consider when selecting an enteral nutrition formula. Standard polymeric formulas are indicated for most patients, as I said. You really need to evaluate medical necessity and clinical outcomes prior to selecting specialty and more costly formulas. And hopefully, the information I provided in this webinar will be helpful by utilizing the guidelines that these nationally and international professional society have done research so that you are better equipped to select your enteral nutrition formula for your patient. Thank you so much for your time, and I appreciate your attendance.
Hi, and welcome to the live Q&A session of our program. My name is Kinsey McNamee. I'm the Enteral Category Manager here at Medical Service Company. Lisa, thank you for joining us this morning, and thank you so much for that presentation about selecting enteral formulas. You provided so much great information and detail around the different formula types, and we do have some questions that we'd like to go over, so I will go ahead and get started with that first question. So the first question is, are there any emerging trends that might influence future updates to evidence-based guidelines for enteral nutrition formula selection?
Okay, thank you. It's been a pleasure, Kinsey, to do this presentation. And yes, there are emerging trends that I think will be extremely relevant. I think one of the things people are focusing on now is more personalized nutrition and looking at people's specific nutrigenomics, their nutrigenetics, and see how individuals' genetic variations are impacted by nutrients. So I think that's an area that will be very relevant in the future. Also, as everyone's heard, the microbiome and gut health is key for immunity. And there's ongoing research now on the gut microbiome and what nutrients are going to better produce bacteria that are going to be beneficial for the host, meaning us. So I think that's an area that's really emerging. The other thing is digital telehealth. I think, as you've heard, there's a lot of technology now, digital health companies that really focus on monitoring and assessing nutritional status, wound care, remotely, so that there'll be better telehealth platforms for individuals to monitor patients. And there's always ongoing research on disease-specific formulas and outcomes.
And the new bill that's being proposed about expanding MNT beyond diabetes and kidney disease. So that's very exciting for the world of nutrition and opening the doors to more of that telehealth and kind of like you're talking about individual monitoring. So it's exciting.
And also sustainability considerations. I think with that being a concern, nutrition formulas may be modified to more consider the environment and things like that as well.
Yeah. So the next question that we got is, are the pulmonary formulas effective for the non-intubated patients, like your basic COPD patient living at home or in a facility?
It really hasn't been shown in studies to be effective. For a lot of COPD patients, they need more calories because the work of breathing increases their energy expenditure. The nutrient dense formulas are typically what's given for those patients because many of them also are volume restricted. But as far as the pulmonary formulas that are low in carb and high in fat, as far as the CO2 production element, no.
Okay. And then could you provide a little more information about fiber content in formulas? So it seems like in some patients, higher fiber causes constipation, and other it may cause diarrhea. So in your opinion, what's a good place to start to kind of optimize tolerance with that fiber content?
That's a really good question because tolerance to fiber varies among individuals. And I think, some benefit from high fiber, some people have issues with high fiber. So, really, the key thing is, I think, to go slowly with the
Okay.
fiber that you're giving the patient just to see if they tolerate it. And also to look at the type of fiber. Is it soluble, which is the fermentable fiber that, like I said in my talk, degrades down to short chain fatty acids? Or is it the non fermentable, insoluble fiber that's more used to increase fecal weight and bulk? A lot of these formulas are a mixture, so really gradually introduce, and also looking at the patient's medical condition is key. Obviously, you don't want to give insoluble fiber to someone with bowel ischemia or severe diabetic gastroparesis. So it's kind of a thing where you just have to individually
Kind of
monitor.
that individual approach that you were
Right,
talking about.
right.
Yeah. Then what about fluid needs? So there seems like that's an area where there's a little bit of confusion on the role of free water and free water flushes. Again, is there a good starting point, like a recommendation for fluid needs?
What I first recommend is to figure out what is the patient's fluid requirements for the day. And there's different formulas that you can use. There's the holiday SIGA formula, where for the first 10 kilograms of body weight, it's 100 milliliters per kilogram per day. The next 10 is 50, and the additional after that is 20. Um, the key thing is, I think people forget, is to figure out how much free water is in these Enteral formulas. If it's a 1 cal per cc formula, you're getting a lot of free water in the formula. So you've got to subtract that from the total amount folks need. The other thing to really consider is the patient's metabolic state. Are they febrile? They're going to need more fluid. Are they having fluid losses through ostomy, vomiting, diarrhea, things like that? So water flushes have to be incorporated into the daily regimen based on that. And they're typically so much per every 4 to 6 hours. And water flushes also help prevent tubes from clogging as well.
Right. Perfect. Well, thank you again, Lisa, for joining us today. Thank you for that great presentation. A lot of really good information about, really, I think you touched on all the different categories of formula and disease state. So thank you for joining us today and have a great rest of your day.
Thank you so much. It was my pleasure.
Thanks.